Hello and welcome to Healthline 3. I'm Terry Simmons. Today we're talking with Dr. Milan Mody, spine specialist with the Orthopedic Clinic of Willis-Knighton Health System, and we'll be discussing minimally invasive spine surgery. We'll be taking your calls throughout the show, so make sure you're in a quiet room with your TV turned all the way down before making your call. The number is 318-219-4569, and you'll see it at the bottom of your screen during the show. Dr. Mody, thank you so much for being here.
Thank you very much for having me. It's a pleasure to be here.
That's fascinating to hear everything that you've been telling us about with spine surgery. And we've got some models here. You've got a demonstration for us. But first of all, let's talk about who needs surgery and how is it decided?
So I think before we can get to who needs surgery, let's talk about how prevalent neck and back pain is.
Yeah.
Over 90% of the population will experience neck and back pain in their lifetime. Majority of time is a very acute pain, which is pain that goes away within less than 4 to 6 weeks, with minor medications, minor activity changes, or a steroid pack or something. So not all that neck and back pain has to be evaluated by a surgeon, but we have patients who come in for that evaluation, and if we can reassure them, teach them what's going on and why there's pain, which comes from inflammation, if we can decrease that inflammation, that we can decrease their pain. So as I said, majority of the population will experience some sort of neck or back pain episode in their life. The ones who experience it more chronically, so ones who are experiencing it over 3 months or greater than 3 months time, we're also not only having neck pain, but also arm pain, or back pain and radiating leg pain, or trouble walking. Those are the patients, that often may require surgery, but not always, As I was telling you earlier, between myself and my associates, we see between 5,000 and 6,000 patients every year. But I do about 250 to 300 surgeries in a year. So that tells you that, look, if you do the math, about 5% of the patients that we see and evaluate need surgery and can benefit from it. The other 95% do well without surgery. And so when we talk about non-surgical treatment methods, it's usually a multidisciplinary approach, physical therapy, chiropractic care, aquatic therapy, spinal injections, medications, TENS unit. So there's a lot of different, in massage therapy, and there's a lot of different things we can apply, and finding the right fit for that patient is very, very important. The ones who fail those options, fail those interventions, then those are the ones who need surgery to help their pain or their dysfunction or the weakness.
Okay, and that's probably very encouraging to hear today that out of 5,000, you do maybe 250 surgeries from 5,000 cases that you see with neck and back pain, because you're right. I think at one time or another, almost everyone has some kind of a stiff neck or they feel like they've tweaked something in their back. And you said up to 3 months if it's that chronic. How do we know in that time if this is something to see a spine specialist? And do we start with our regular doctor? Can we come straight to you? How do we know when it's serious enough maybe to see a specialist?
So, we have call-ins all the time, daily call-ins, and we'll work them in either the same day or next day or within that week with acute pain. Mm-hmm. But sometimes they'll call their primary care doctor. So either way is fine, so they call in to our clinic, we'll get them in and kind of get them evaluated, get their x-rays, get their examination. If things require progression to like an MRI or a CT scan, then we'll sort of move ahead with that. Majority of times, when it's really just a few days or few weeks of pain, it's a reassurance, it's an education of the patient, very, very important. And then letting them know that this is not uncommon, it's quite common. And we actually have handouts for them about home exercises they can do. And then get them in with either just a home exercise program and some medications, or actually get them in with physical therapy first. And then if they're still having symptoms, they're still having problems, and more imaging such as CAT scan, MRIs, nerve studies. But yeah, so they can either start with a primary care or they can start with us, spine specialists.
Okay, and don't be afraid to call and ask you. Sometimes somebody may feel like, oh, I don't want to jump the gun, it's probably nothing. But if it's bothering you, it's painful, it's worrying you, go ahead and call. At least nothing, you'll be educated, you'll be learned, because there's muscles involved, there's nerves involved. And you talked about going down, there's referred pain, which might be in your arm, but it's coming from something pinched or something wrong with the spine. So explain that.
Correct, no, definitely. Yeah, so you're right. Don't be afraid to call.
Yeah.
As they say, there's no stupid questions
Right.
ever. It's one of the reasons why, when you ask me what title, I said spine specialist, not a spine surgeon, because I think patients think that sometimes when they see a spine surgeon, that surgery is their only option, or
Yeah.
surgery is what I'm going to recommend, and that's not the case. So anyone, when a primary care doctor sends a patient to us, they're a little apprehensive as well, because again, they see surgery as part of our the banners, and when they walk in, but tell them, look, this is an introduction, and then we don't always have to resort to surgery, and we use surgery as the last option. And you had a question about that neck pain being referred into the arms, so that's very common. This is not just neck pain, but it's also radicular or referred pain, and so those are little nerves that come down. So this is the model of the neck right here. And so these are the bones of the neck, and these are disc spaces right here. So bone, disc, so forth. And each area, if you see these yellow areas right here, and those are the nerves that come through there. So imagine if a disc is bulging or ruptured, it pushes on the nerve, which then is going into the arms. And that's why people will have that happening. Sometimes it's just an arthritic condition, little, you've heard the word spur. So similar kind of spurs happen in the neck as well. And so the spur can hit the nerve and cause that pain going down. Sometimes it's numbness, sometimes it's pain and numbness, sometimes it's pain, numbness, and weakness. And then weakness can also lead to what's called dysfunction, which is, they can't hold a cup of water, a coffee mug, can't turn a door handle, or handwriting changes. Their fine motor skills are affected. So they enjoyed calligraphy, and they enjoyed knitting, they enjoyed model railroad or model airplane. They can't do it because these are fine motor skills that these nerves from the neck are coming down into the arms, causing problems and dysfunction.
Okay.
And those are very, very important things to kind of look out for. So it's not just pain.
Right.
I know we always focus on pain, but also dysfunction. And to have that evaluated is a good thing. Your body is speaking to you through its symptoms. So I tell patients to listen to your body. It's sort of like when patients have chest pain, it's coming from their heart. So to listen to your body.
Okay, we have a caller for you already.
Okay.
Matt, what is your question? Thanks for calling.
Absolutely, yeah. So I'm an avid golfer, and having some pretty bad back pain for years now, and I'm just curious if surgery would help me, kind of like it did Tiger Woods.
So you're asking if surgery would help a golfer like it helped Tiger Woods. So, about 30 to 50% of golfers in their sort of golf career, whether they're a weekend golfer or a pro golfer, who have experienced back issues requiring a specialist. So if you look at the major sort of pros, Tiger Woods, he mentioned Tiger Woods earlier, Jack Nicklaus, Lee Trevino, these are all people who've had spinal surgery. In fact, Tiger Woods has had 5 surgeries on his back. And if we look at his last performance, he had what we call a spinal fusion. He had 2-level spinal fusion, lumbar in the low back, and he's come back playing very strong. But a lot of my golfers, we don't always need surgery to get back to a good game. So I tell them, look, we got to get their core correct. We got to get their hip flexors looser. We got to get their alignment of their spine better, because what they do in golf is your feet are firmly planted on the ground, and your upper torso, your upper body is generating this wild swing through that. So it generates about 1,000 to 1,700 pounds of compressive forces across your spine, and that amount is enough to rupture a disc. The best way to kind of avoid rupturing your disc in your low back is to warm up. So give yourself at least 20 practice swings, warm up for at least 5 to 10 minutes, and then the most key part is once you're done with a game, once you're done with your 9 or 18 holes, whatever you're playing, also warm down. So that's very key. That's where the pros also do, and sometimes they forget because they want to hit the clubhouse to get their Arnold Palmer, but it's very important to do warming up, the stretching, and then warming down, stretching again, and pay attention to your core, pay attention to all your muscles such as the glutes, the hip flexors, and the spinal muscles.
Does that answer your question, Matt?
Absolutely. I really appreciate it.
Oh, sure. Thanks for calling, and good luck with your golf game. And so we talk about the core too. We're talking about with the lower back and how all these muscles work together, and they can affect the dysfunction. Also, strengthening your abdominal muscles will give you a stronger back. Is that true?
Very true.
Yeah.
And that's where the therapy comes in. That's where home exercise programs come in. I think it's very, very important to strengthen your core muscles, not only when you have back pain, but also when you don't have back pain.
Okay. All right. And I think we have another caller for you.
Yeah.
Is it Cheryl? What is your question?
Hi. This is difficult. My doctor, I went to see my doctor when I got hurt, and she took a x-ray of my spine in the lower area, and she said the cartilage was gone between the vertebrae, but then never did anything. And can you put it back?
The cartilage is gone. Can you put it back? You want to put your earpiece in your ear. You might be able to hear a little better there.
There you go.
Yeah, that's what I guess. Can they put it back, the cartilage?
So we can't replace cartilage yet. We don't have spare human parts laying around. We will be there someday. I think not in my lifetime, and then maybe in our grandchildren's lifetime, maybe. But we're getting there.
Well, I already have grandchildren.
Yeah.
So they'll be able to.
I'm not going to make it that far.
Yeah. But we can help spread the two bones out. So if there's bone on bone, that's what we talk about. When you have hip and knee surgeries, it's usually because it's bone on bone. There's no cartilage left. So very similarly, this happens to the lumbar spine and cervical spine, which is the cervical spine is the neck, lumbar spine is the low back. It's that bone on bone that hurts. And not only does that happen, but when the bone comes on the bone, there's no disc separating the two issues, then the nerve gets pinched. And because the nerve is getting pinched, that's where it causes the pain, not only back, but buttocks, leg, in the lower back. In the neck, it's your neck, shoulder, and arms, because it's the neck getting pinched. So you can't replace cartilage yet, but what we can do is put a spacer, an artificial spacer, or sometimes we call it disc spacer. Sometimes people call it a cage. But what that does, it keeps the bones separated and also keeps the nerve free. And that's where the stenosis, or the pressure on the nerve, is causing the pain. So there are treatment options for people such as you who have lost their cartilage between the bones.
Does that answer your question?
So how do you? Yes, I know I have options now, but the next question is how do you get to somebody like you?
That's a very good question. So your primary care doctor can often find us and refer you to us. The other option is to call us directly, and if it's okay, I'll give my
give the phone number. Write this down.
So 318-212-3610, 318-212-3610, and that's the orthopedic clinic, we also have a website. If you forget, phone number, call. Just go to TOC, Shreveport.com. The Orthopedic Clinic, TOC, Shreveport.com, and you can either come see us or my other partners who specialize in hands, shoulders, knees, and hips, and foot and ankle.
Yes. So if you go to the website, you can see all of the things that they do that they can help you with. It's very informative, and all of the doctors listed and everything. So did you get all that information?
I think so.
Okay.
Are you with the Lewis-Knighton Health System, or with Shumpert or LSU?
So I'm with the Willis-Knighton Health System, and I also teach at LSU with the School of Medicine and the Department of Orthopedic Surgery.
Okay, thank you. I really appreciate it.
Thank you.
Thanks for calling. Good luck to you. And so we talked about open surgery, open back surgery, and the minimally invasive. So what is there's the obvious difference. What are the other differences, and how does someone decide, or how do you decide what's going to be the best way to operate on someone?
So you've heard the old adage that you cannot hit every nail with the same hammer. Same way with surgery, is not everybody requires minimally invasive surgery. Not everybody requires open surgery. So depending on the patient factors, whether it's their MRI or their symptoms, along with their medical morbidities. So if they're diabetic, if they have a heart condition, if they have a pulmonary condition, so what surgery is best, and that's how we would choose open versus minimally invasive. Many techniques now have moved towards minimally invasive. So techniques these minimally invasive techniques have led to shorter recovery time, very short length of stay in the hospital, enhanced recovery, and improved patient outcomes.
Wow. Okay. It's a good thing to decide. A lot of options there.
That's right.
We have Rendell on the phone. What is your question? Thanks for calling. Are you there?
Hello.
Hi. Hello. What's your question?
Okay. Now I have a spare. I have a spare in my back, and what I'm saying, and also I have they had found a cancer spot on my lung, and I've been through chemo and registration, and I can make a certain move, and I can feel that spirit, and I feel that spirit. That spirit it be stinging me and all that kind of stuff, and I need to see a specialist. And I need to see a specialist for that.
Okay.
Most definitely. It sounds like you definitely need to see a specialist. Now we have patients who have, like you have, gone through chemo and have a cancer issue, but also have a spinal issue. So we work with your cancer specialist in deciding what's the best treatment for that for you. There are certain spinal injections we can do. There are certain modalities we can utilize. But we work with your other specialists in terms of deciding what's the best treatment for you. So essentially, we talked about earlier, not hitting every nail with the same hammer. Same thing for patients is, we call it idiosyncratic. It's tailored to the patient and their other factors. Whether it's psychosocial support structure, whether it's their medical comorbidities, as in your case with the cancer. But there's definitely treatment options for everyone.
So should he give you a call maybe and
Sure,
come
yeah.
see
So
you?
again, call us at 318-212-3610. 318-212-3610.
Okay. So there's help for you. You can give him a call. Does that answer your question? Rendell, you still there?
What is his number?
Go ahead. One more time.
Can I get his phone number?
Yeah, write this down. You ready?
318-212-3610.
Okay, yeah. Okay. Hold on, sir. Okay. You say it's 212.
Correct. 3610.
Okay. 3610.
That's it. You
That's
got it.
We look forward to helping you.
Okay.
Okay. You take care of yourself. Thank you for calling.
Thank you.
Okay, now Dr. Mody, we've got some demonstrations. You've got a demonstration here. We've got some models. This is what you actually use in the office when you're explaining to people about their possibilities, what they might have.
That's correct. They say a picture's worth 1,000 words, and so we do often use models and pictures and things to explain to patients. So we have As we talked about earlier, this is the neck model.
Okay.
This is the base of the skull, and then the bones and the disc and the nerves of the neck. And this is right here, this is the what we call lumbar spine.
And is that in the middle back or
That's
lower?
in your
That's
lower
the
back. Yeah. And so again, bone, disc, discs, and so forth. So each disc is separating two bones. And then also is a nerve on the left side and then nerve on the right side. And if you look down the middle of it, you'll see the spinal cord. So the spinal cord and the nerves live in the middle of your spinal canal, and these bones protect that. But as we age, these bones overgrow, and they cause this bone spurs, and can cause pinching of the nerves secondary to that. So that which is meant to protect us in our younger age and in our development, also can lead to issues in the future.
Okay. Oh, we have Judy on the line. Hi, Judy. Thanks for calling. What's your question?
Hi. I'm in my 70s, and I have stenosis in my neck. My arm hurts. My left arm hurts a lot and is weak. And I wonder if that's something that could be corrected surgically or non-surgically. And if it's surgical, how much risk would I have?
All very good questions. Something we see quite commonly. What you have is something called cervical stenosis, which is pain with this pressure on the spinal cord of the nerves in the neck. And that can cause neck pain, shoulder pain, and arm pain. That can also cause achy feeling in your arms. It also causes dysfunction, which your hand's not working well. Majority of times we can treat that with physical therapy along with traction. We can also treat it with some medications for muscle relaxant or anti-inflammatories. We can also treat it with spinal injections. So we can do an epidural injection in the neck under X-ray, and then coat the inflamed nerve with a steroid medicine. So again, we're decreasing inflammation, which also decreases the pain. Sometimes when the stenosis or the pressure on the spinal cord and the nerves is severe, which can also lead to severe weakness and dysfunction. And sometimes you'll lose muscle in your hands. We call that atrophy. So the muscle's being lost, where a patient can't open a jar, can't open the door, can't use their shifter in their car, or their handwriting is terrible like a doctor's. Those are things that we look for also when to decide if they need surgery. Majority of times when people have severe pressure on the spinal cord in their neck, surgery is a better option in the long run. And then, you asked about the risks. So we go through the benefits and the risks with every patient. We help to optimize the patient outcome and minimize their risks by going through what we call risk stratification. So we'll have a patient go through their medical doctor, get a medical checkup. If they have a heart condition, we'll have them go through a heart specialist. If they have a lung condition, we'll have their lung specialist, and see if they qualify for surgery and where they're stratified, if it's a low risk, moderate risk, or high risk. And then we'll have a conversation with the family about what's the best option for that patient. But we've had plenty of patients in their 70s, 80s. The oldest one I've done the neck surgery on was 96, and he came out of it just fine. And I know you celebrated 100th birthday, and I got a card for that. So,
oh, wow. Yeah. How about that? Does that answer your question?
It does. It helps me a lot.
Oh, good, Judy.
Thank you.
Sure. Thank you so much for calling.
Thank you.
So you have a demonstration. Do we have time? Do you want to do that and show it to us?
Sure,
Or
definitely,
okay.
yeah.
Do you need my help?
No, I think what I'll do is, so this is a tool that we use for minimal invasive spine surgery.
Okay.
It's not commonly utilized, but something I've been utilizing for the last 10 years or so. We've sort of improved the technology. It's gone smaller and smaller. But this is something called a pediguard, and it's when we put screws into the body of the vertebral body. So I'll show you what the screws look like. So these are titanium screws. So they're put into the bone, and they're done in a robotic or minimally invasive fashion. So the screws go in on the side into the bones itself, so you can actually see the the bone itself and the titanium screw going in. And the spinal cord actually lives in this area, the spinal nerve. So you can see how it has to be protected
Yes.
from these things. And so there's a lot of different ways we minimize those risks. One way is technique and training, being very careful. And then the other way is this little device that helps with that. It's called a Pediguard. And so if you'll let me demonstrate, this is the sharp part of it right here. That's the needle that goes into the bone itself. But if it's in bone, it makes a different noise, a different sound than when if it's near nerves or if it's near the spinal fluid.
Oh.
So if you'll see, what I did was I filled a cap with water here, which will demonstrate a little soft or fluid. And you'll sort of I guess they're not doing it right now.
Do you want to try this one because it didn't have the?
Yeah, let's try that one.
Because it'll make a sound too when you
Yeah.
pull that ribbon
Right.
out.
So we'll try this one right here.
There we go. So this will make noise, and that's how you can tell? Like, is it loud noise like out in the open like that, or do you have to have special equipment while you're?
Yeah,
There we go. So it will tell you there's an alarm when you're getting toward tissue that you shouldn't be getting near,
correct,
right?
exactly. Yep.
That's good to know.
So
Those are some big screws.
Technology malfunction.
Yeah.
But again, it makes a very, very fast beeping sound if it's in water versus if it's in bone.
Yeah.
Yep.
So.
So there's a lot of, we also have other techniques such as an ultrasonic scalpel, so which only cuts bone. And of course we talk about robotic.
Yeah, okay. And before we get to that, now we've heard you say that the spine is like a car, right?
Yes.
Explain, what do you mean by that?
So what I often do, patients don't sort of get the concept that there's degeneration, they're in their body, they may be in their 40s or 50s. So I'll often will look down at their chart and look at their date of birth. So let's say they're born in 1972, so that makes them about 50 years old. So imagine a car you bought in 1972, and if that car has been on the open road, you're driving that car, you're getting mileage, then there's parts that wear out. So tires, brake pads, windshield washers, those wear out because there's wear and tear on them. But dashboard or your mirror, your rear view mirror, there's no wear and tear on that because they're fixed components, they're not moving. So it's very similar in the body, your discs are like tires in a car. And so when you're moving through your life, just imagine there's mileage on it, but you want mileage. You don't want a car that you bought in 1972 or 1962, 1952, just sit in the garage under a tarp. Sure, there'll be no wear and tear on it, but you really didn't enjoy driving that car. Yeah. Same thing with your body. When you use your body, and it's functional to keep functional and stay functional as long as you can.
Right. Okay, that's a good analogy. So you want those miles, you just want healthy miles and maintenance along the way and taking care of it. But there is going to be some, you drive it off the lot, then it's already going to start going a little bit lower in value, or it's going to have some wear and tear depending how you've done. So that's a really good way to look at it. There's just normally, the longer you live, you're going to have a little bit of, and that's why we have you.
And that's why if you look at the car analogy, is we have maintenance. We go go to the mechanic, we get our oil change every certain 1,000 miles. Same thing with your human body. That's what we have physicians. That's what we sometimes replace parts, and sometimes we tune them up.
We'll replace the part and tune them up.
That's right.
Anyway, all right. Thank you so much. This has
you.
been really fascinating. Thank you for bringing all of this for us to look at, and the questions were really wonderful. Our viewers are really great at calling in and asking something to really emphasize on the different surgeries and everything available. So we really appreciate you being here.
Thank you very much for having me.
All right. Any one thing you'd like to leave our viewers with before we close?
It seemed like they wanted our phone number
Yeah,
quite often.
give the phone number, yeah.
Yeah, so I'll give them 318-212-3610. And they remember nothing else out of this. Just stay on the open road and stay functional.
Sounds good. Thank you so much. It's
Thank
been
you.
such a pleasure.
Same
and it's
here.
the Orthopedic Clinic.
The orthopedic
that's
clinic,
what we call
correct.
you. Okay. And different types of surgeries, minimally invasive, open, everything there. And also go to the website. They can find out all kinds of things about your associates also.
That's right.
All right. Thank you for joining us today for Healthline 3. We'll see you next time. Enjoy your afternoon.